Hi, everyone. This is Shalini Wickramathilika from 2020 Mom. Thank you all so much for joining this breakout session. I just wanted to start off with a couple housekeeping items before I hand it over to our speakers today. Just so everyone is aware, this session is being recorded so that those who are unable to attend live can watch the recording at a later time. All attendees have been muted upon entry. The PowerPoint presentation that will be shared today will be accessible via the Whova platform for download after the presentation. Also, please note that we are hopeful that we'll have a robust Q&A after our speakers are done. But note that we'll be using the chat box for questions. So as questions pop up for you, just feel free to type them into the chat box, and Sidra and Julie will get to them towards the end of the presentation. So I will now turn it over to Sidra Goldman-Meller to kick us off.
Great. Thank you so much, Shalini. Hi, everyone. Thank you so much for attending this session. We are excited to engage with everybody today. I will go ahead and share my screen. All right. So my name is Sidra Goldman-Miller. I am an associate professor of public health at the University of California, Merced, which is the newest campus of the University of California system. I am a psychiatric epidemiologist by training, and most of the work that I do over the last sort of 5 or 6 years, maybe longer than that, is on suicide and suicidal behavior. And the work that I'll be presenting today is stemming from kind of a newer area of research that I work on with several collaborators, whom I'll talk about a little bit, that is looking at pregnancy associated suicide. So I'm happy to be here today, and thank you all again for coming. So what I'm going to do in my presentation is give some kind of background and context to the problem, and also talk about results from a recently published study that I and my collaborators just published. It came out just really over just about a month ago. And then Julie's going to talk about interventions, a specific intervention kind of protocol or plan that could be of relevance. So, all right, so in terms of context, so as I probably don't really need to tell this audience, pregnant and birthing individuals in the US die at a higher rate than in other comparable high-income countries. So in the US, pregnant birthing people die at a rate of more than 20 per 100,000 live births. That compares, just as an example, to in France and the UK, the maternal mortality rate is about 7 or 8 per 100,000. So we are kind of way out there in terms of having this extremely high rate of death among pregnant and birthing individuals. So reducing that death rate is obviously a public health priority and a clinical priority across the country. Most of the emphasis, and when I say that reducing these deaths is a clinical and a public health priority, most of the evidence or most of the kind of effort around that is geared towards kind of what are perceived to be kind of the major causes of death. So due to obstetric and sort of gynecological problems that kind of immediately result from the pregnancy or the birth. There is some emerging evidence from specific states, kind of single state studies, that have suggested over the past several years that suicide may be a more common and potentially increasing cause of death during pregnancy and that first year postpartum than we have been kind of previously aware. But up till now, or kind of recently, this incredibly devastating outcome has received a lot less attention in the kind of public health and the clinical worlds than other causes of death. And that is due in part to sort of terminology or definitional issues in the United States. So I just want to go through a few kind of key terms so that everybody is on the same page and kind of and is aware of the sort of differences in the meaning behind these terms. So the circled terms here, maternal mortality and pregnancy-related death, these are the terms that the CDC uses and reports on when it is reporting on statistics about deaths that are occurring during pregnancy and the postpartum period. The most kind of widely used term is maternal mortality, which is specifically defined as the death of a woman while she is pregnant or within 42 days of the end of pregnancy, so within 6 weeks. And that death has to occur from a cause that is related to or aggravated by the pregnancy or its management. So it's kind of directly related to the pregnancy. So these, it is kind of that still encompasses a pretty wide spectrum of causes of death, but hemorrhage, hypertension, venous thromboembolism are some examples that would fall into that category. Notably, the term maternal mortality does not include any what's called accidental or incidental causes, including suicide. So it doesn't include any kind of accidents, it doesn't include homicide, it doesn't include drug overdoses, and it doesn't include suicide. The term pregnancy-related death is basically the exact same term as maternal mortality, but instead of it referring to deaths that occur within 42 days, the term pregnancy-related death refers to deaths that occur within 1 year of the end of a pregnancy. But again, it does not include suicide. So when CDC is talking about these things, they're definitionally, they are not talking about deaths that are due to suicide. Pregnancy-associated death, however, or PAD, this is an alternative term that is gaining a bit more traction, and it refers to the death of a woman while she is pregnant or within 1 year of the end of her pregnancy from any cause, no matter what. And so that, by definition, includes suicide. And that's the term and the concept that I'm going to be talking about or using today. I also want to briefly mention this term maternal morbidity. Morbidity itself, just as a kind of a public health term, refers to any non-fatal illness or injury, so it's contrasted with mortality. And you probably have heard this term severe maternal morbidity or SMM, which refers to unexpected outcomes of labor and delivery that result in significant serious consequences to the woman's health. Again, it's this kind of list of specific outcomes that include myocardial infarction, renal failure, eclampsia, sepsis, and so on. But it does not include any mental health or substance use disorders. And so I'm not really going to talk about maternal morbidity today, but you kind of get this sense of that when we're talking about maternal health and morbidity and mortality, a lot of this conversation is just leaving out mental health and drug use and suicide and self-harm altogether. So, like I said, there have been state-specific reports or research looking at suicide rates, pregnancy-associated suicide rates, but the last US-wide estimates of suicide rates during pregnancy and the postpartum period were actually from 2010. So when my colleagues and I set out to do this research, the last sort of US-wide estimates that we had to go on were from 2010. But as we all know, a lot has happened since 2010. In particular, as for most relevance to this project, the health of reproductive aged women, not specifically like pregnant or postpartum women, but just in general, the health of reproductive aged women has changed since then in a variety of ways. But one of the most crucial ways for our purposes is that we have seen rising rates of suicide among reproductive aged women, but in the last 10 plus years. So you can see the chart on the right where it starts from a real kind of low below 6 suicides per 100,000 women in 2010 to actually over 7 suicides per 100,000 by 2018, and then it dipped a little bit in 2019. So that's a pretty pretty big increase over a 10-year period. That 10-year period also saw fertility declines in the general population. So fewer women having babies, fewer babies per women. And that affects, that may be relevant because the population of women who are becoming pregnant and having babies may have shifted, which could affect the suicide rate. So as in everything with public health, it's important to look at these trends because looking at the trends can help us figure out how to better prevent these incredibly devastating outcomes. So the work that I'm going to be talking about today, we looked at pregnancy-associated death due to suicide, actually, as well as other kinds of deaths. So we looked at drug overdoses and homicides and a few other things, but I will focus this talk just on the suicide findings. So we looked at pregnancy-associated death due to suicide in the US between 2010 and 2019. So I'll present a few different things. We looked at racial, ethnic, and other disparities, and we also looked at when the death occurred in terms of the timing in relation to pregnancy. Okay, so how do we actually do the study? How we measure pregnancy-associated suicide, it's sort of a very basic calculation. It is just the number of suicide deaths in a given year among pregnant or postpartum women divided by the number of live births in that state. Right, so we look at this in a state-specific way, and then we sort of aggregate all of these numbers. So study period 2010 to 2019. So how do we actually identify whether a suicide death occurred in a pregnant or a postpartum woman? Well, we use death certificate data to do that. So this is death certificates that are freely available from US death records. So we restrict the analysis to females who have died between the ages of 15 and 44, so of reproductive age. And we restricted our analysis to states that had adopted what's called the 2003 revised death certificate, and that they had, if they had adopted it by 2010, then we included them in our study. So that's not every state, but it's most states, so 33 states plus DC. So why do we limit the analysis in this way? Well, so I'm showing here like a little snippet of the 2003 revised death certificate on the screen here. And what you can see is that this revised death certificate includes this box, what's called the pregnancy checkbox that's circled here. And the person who's filling out the death certificate, the coroner or the medical examiner, whoever it is, if the decedent, the person who has died, is female, they are required to check one of these boxes that say whether the decedent was pregnant within the past 12 months, not currently pregnant, but known to have been pregnant within the past 42 days, or sorry, within 42 days of death. Then again, like not pregnant, but pregnant between 43 days and 1 year before their death. And then, pregnant at the time of death, or whether whether the timing of this is unknown. So this allows us to see kind of on the death certificate that this person who died was either pregnant or postpartum. So we use the death certificate, that checkbox information, and then the actual cause of death that was listed to classify all pregnancy-associated deaths as being due to obstetric causes, drug-related causes, suicide, which is what I'll talk about here, homicide, or of other causes. Okay. So then to examine disparities and other factors, we additionally classified all of these decedents according to their race, ethnicity, and age as listed on the death certificate. And then we used, again, that pregnancy checkbox information to classify the timing of death as being pregnant at the time of death, pregnant 1 to 42 days before the death, or pregnant 43 days to a year before her death. the last thing that we did in this paper was that we quantified the potential underreporting of suicide deaths. So this is the way we did this is based on another paper that was published back in 2011 by researchers Horan and Chang. And what they were doing, they used data from Maryland so they got death certificate data from Maryland. It had adopted the pregnancy checkbox death certificate format. So they use the death certificate data, but then they compared the death certificate data to a much more formal investigation that was drawing on data sources from lots of different kind of places, medical records, birth records, fetal death records, a whole manner of different data sources to kind of verify whether all suicide pregnancy-associated suicide deaths were actually recorded using that checkbox. And what they found in Maryland at the time of the study was that only 43% of pregnancy-associated suicides were reported correctly on the death certificates. So more than 50% of the kind of true number of pregnancy-associated suicides, only about 50% or less than that really were sort of correctly reported on that checkbox. So we kind of applied that proportion to our data to get an estimate of how many suicides might we be missing. Okay, so what were our findings? So during the time period, during the 33 states in DC that we covered for our study, there were a total of about almost 29 million live births. So that's the denominator here in this equation. And during in those same time period and states, there were 11,782 total pregnancy associated deaths, not suicide deaths, but total pregnancy associated deaths. Of all the deaths in our study, so that 11,782, 558 or about 5.4% had the pregnancy checkbox checked off and a cause of death code indicating that it was a suicide. So about 5.5% of these deaths were suicides. That gives us an overall pregnancy-associated suicide ratio of 2.2 suicide deaths for every 100,000 live births. We also found that about 59% of these deaths were due to maternal or obstetric causes. More than 10.5% were due to drug-related causes. Same exact number as suicides actually were due to homicide, so 4.5% to homicide, and about 19% to other causes. We also saw when we looked at trends, we see that this pregnancy-associated death ratio due to suicide, you can see in the chart here. So it's kind of bouncing around a little bit, but there's a definite kind of upward trajectory over the study period. So between 2010 and 2019. If you look at the difference between 2010 and 2019, the rate has increased 32%. So pretty substantial increase. So then we looked at pregnancy-associated deaths by timing of the death. So these bars are a little bit hard to interpret, so let me orient you here. So if we focus just on the obstetric causes for 1 second, so the darkest gray bar, that indicates what percentage of the obstetric deaths, occurred in women who were pregnant at the time of their death. So about 36% of all obstetric deaths occurred while the woman was pregnant. 35% occurred when she was within 42 days postpartum. 26% occurred when she was between kind of 6 weeks and 1 year postpartum. And then for a very tiny fraction, it was actually the timing was unknown. So if we look at suicide, what we see is that about 36% of the suicide deaths occurred while the woman was pregnant. A very small proportion, so 13% occurred within the first 6 weeks after her delivery. and 51%, so more than half, occurred between 6 weeks and a year postpartum. When we looked at racial and ethnic disparities in these suicide deaths, we certainly do see them. You can see on the slide here that Native American or American Indian Alaska Native identified women had by far the highest pregnancy-associated suicide rate at 7.7 per 100,000. The next most highest were non-Hispanic white women, and non-Hispanic Asian women, with non-Hispanic Black and Hispanic women having the lowest rates. We also see some age disparities. So you can see that the suicide rate was highest among women who were between the ages of 15 and 19, so that the youngest women. And then the next highest rate was among the oldest age group that we looked at, so women who were over 35 at the time of their death. So then we looked at this accounting for this underreporting of the suicide deaths, right? So this is kind of going back to that Horn and Chang paper, trying to statistically account for what seems to be this underreporting of suicide deaths on using the pregnancy checkbox thing. So after we account for that statistically, which I'm not going to go into the boring details of, what we found is that the pregnancy-associated suicide death ratio changed from 2.2 per 100,000, that's the statistic that I quoted you earlier, to 5.1 per 100,000. So it more than doubled. That sort of corresponds with an estimated total of 844 suicide deaths that were not counted, basically, that were kind of not recognized as being pregnancy-associated suicides during our study period. If we add those missing suicide deaths back in, as well as actually the missing deaths, because it's not just suicides that are underreported, so drug-related deaths and homicides are also underreported. So if we kind of statistically account for like all of that underreporting, then sort of recalculate the total estimated number of all pregnancy-associated deaths, what we found is that suicide would actually account for about 9.5 or 9.4% of all pregnancy-associated deaths. So a much higher fraction than 5.4%. Okay, so what do we conclude? So our kind of the major kind of findings here, just to reorient everyone, is that suicide among pregnant and postpartum women does seem to be increasing over the last 10 years. And suicide accounts for a non-negligible, I mean, really like fairly substantial proportion of pregnancy-associated deaths. Most of those deaths, 64%, are occurring postpartum, and the vast majority of those are occurring after the 6-week checkup. So right when, like, you know, that checkup may be the last time that a woman sees a provider for her own health in her postpartum period. So we know that, you know, from other research that women may be, you know, struggling with all manner of things. So lack of support, you know, mental health problems, drug overdose problems, et cetera. So that it seems to be kind of culminating or kind of spiraling out in that post 6-week checkup period. We also observed just really unacceptable racial and ethnic disparities in the death in pregnancy-associated suicide deaths, with American Indian and Alaska Native women at far greater risk. So their risk was about 3 times as high as that among non-Hispanic white women, who themselves like were at higher risk, you know, compared to other racial and ethnic groups. And lastly, we also found that the contribution of suicide, as well as drug-related deaths and homicide, to the overall pregnancy and postpartum mortality is likely to be a lot higher than the kind of unadjusted estimates would suggest. So I will end there. My contact information is provided there. I'm happy to answer emails. I do want to highlight my amazing team of collaborators here. So Claire Margerson is at Michigan State University. She's the first author on this paper that we just published. Megan Roberts is her graduate student, and Allison Gemmel is a colleague of ours who is at Johns Hopkins. And I would like to acknowledge our funding. This particular study was funded by 2 grants from the National Institute of Child Health and Human Development. And I think we're going to wait until the end for questions and comments. So I will now hand it over to Julie.
Thanks, Sidra. It's such a great opening for what I'm going to talk about, because what I'm wondering, and if we were in a room, I'd do a show of hands. What I'm wondering is how many of you are thinking, okay, either so what do I do? Or boy, I don't know that our suicide care practices are really up to, up to speed. Like I often say when I work in when I'm giving a presentation, if your loved one was at risk for suicide, your wife, your mother, your daughter, would you take them to your healthcare system and feel really confident that they would get good care? And typically less than half of the room raises their hands. So what I'm going to talk about is, it's a little provocative, and I want you to think about that question as I'm talking. Do you do these things, and what can you do better? So I'm going to be talking about our Zero Suicide Framework. I'm Julie Goldstein-Grummet. I'm the director of the Zero Suicide Institute at the Education Development Center. And oh, Sidra, could you advance the slide? Sorry, I forgot I don't have control over that. So Zero Suicide, it's really a comprehensive approach to how we need to think about suicide care in a healthcare system, and that includes obstetrics. There are suicide prevention practices that work, and we should be using them no matter what door somebody at risk enters. The idea is that suicide is preventable. That in itself can be controversial, but I think to think about if we know about it early enough and we embed practices, then most of the time, maybe not every time, but most of the time, we can give an opportunity for people to disclose their risk. It is a zero-based mindset. So anybody who's familiar with the concept of a high reliability organization, HROs, this should speak to you. It's measurement-driven improvement. Everything you do, you have to measure, are we doing it? Are we doing it with fidelity in the way that we say we are? It's the embedding of evidence-based clinical care practices with suicide clinical workflows to ensure that everybody knows their role and what comes next. Absolutely incorporates lived experience. You can't make processes and practices if you don't know that they're going to create the doors that you want for people who are feeling this way to come forward and talk about how they're doing and how do you install hope in these situations. And it's a just culture that holds systems accountable, but not the individual. Again, the idea of a just culture is a no blame environment. And so anybody who is familiar with that concept is really the idea that in a system of care, you don't look to blame an individual when an adverse event happens, but that it's an opportunity to fix some kind of a crack in the system that you can fix a never event. Next slide. So Sidra even talked about this a little bit, which is why should we think about suicide in healthcare? I think Sidra raised this, right? 38% of individuals have been in healthcare in the week before their suicide attempt, 95% within the year before their attempt. About 80% of those who die by suicide within the past year have seen a healthcare provider. It's interesting that Sidra said many people after that 6-week visit is when they die. I have 3 kids. You certainly see your healthcare provider a lot when you're pregnant, but think about, to what extent is your OB laying the groundwork for how you're doing and how you're feeling, and would you come back and talk about suicide? I know even in my pediatrician's office, they asked how I was doing. So I think every door, again, has to be the right door, because we know most people are not going to talk to a behavioral health provider for many reasons. You're a new mom, you have limited time, maybe you have other people at home, other kids at home. Maybe you tried and it wasn't very well received, or it was very traumatic. It can be very embarrassing. I've certainly heard many new moms talk about this. It's supposed to be the best time of your life in many ways. You had this baby. especially people maybe who went through fertility, and and now you're having these horrible thoughts of wanting to be dead. And how do you tell people that? So it brings with it shame and stigma, and how come other people around me can take care of their kids and I can't? And I think part of what we're really thinking about in Zero Suicide is, what is the way in which you create an environment that makes it safe and comfortable and not judgmental, to talk about suicide. And again, people are very busy in healthcare and we don't have a lot of time for these practices, but there's a big difference between face-to-face conversations that are open and engaging and really suggest, I want to know how you're doing. And even if you don't feel this way now, what you're doing is laying the opportunity that if you feel this way in 1 month or 6 months or 6 years, this is a door that we can talk about this. I think it really kind of helps to, it helps in the same way that we have to do height and weight and blood pressure at every visit. And we don't say, why do you have to do that? I mean, maybe sometimes after having a baby, you might feel that way, but really, those are normal events that occur at every healthcare visit, and we don't even second guess it. And we have to feel that way about suicide care and suicide care practices as well. And that includes providers who feel comfortable asking about suicide. And I'll talk about that in a moment, where, what does the research say about how do you talk about suicide? Next slide. So the Zero Suicide Framework, it's made up of 7 evidence-based components. Doing each of these is really critical because it really is the bundle of interventions that works to reduce suicide. Systems that have adopted this entire framework have reduced suicide in their population by 65 to 75%. And it's not something that you do in a year, and it's not something that you do once and you move on. It is really a continual process to work towards doing each of these effectively and well, and doing them simultaneously. And you're not going to adopt the whole framework at once either. It's not something you can adopt overnight, but we do know that the sum of these parts, when working together, reduces suicide. Next slide. So as you can imagine, leadership is really critical. When it comes from the leader that suicide is preventable, it is a target of ours, we absolutely can impact suicide. We have this opportunity, and shame on us for having not taken this as our responsibility, as a core responsibility in the past. When leaders message that things can change, things can improve, this isn't just sort of the flavor of the month, that this is critical to us, that we're going to give you the resources you need to do this, that is what works. I'm sure you've seen it in your own healthcare systems when you knew that the leaders were really were really behind something with passion and commitment, versus when it sort of felt like, well, let's throw the spaghetti at the wall and see what sticks and maybe move on. Healthcare systems where leaders absolutely are committed that suicide is a never event in their system, and that it is an absolute responsibility of every provider and every person who works in that system. It's not just the licensed physicians and psychologists and psychiatrists. It's everybody who works in the system plays a role, and they know what their role is, and they are meant to feel equally as important, right? We hear about Toyota and the plant where everybody, you don't want the car to leave the factory if the brakes don't work. And anybody can pull that lever and stop and say, it's critical that we don't let that car go. That's how you want leadership to message about suicide care within the healthcare system. Next slide. And as I've already started saying, if you don't know how well you're doing, then how can you improve it? And so every new practice that you embed has to be measured. Are we doing what we say we're doing with fidelity? And are we improving? So I'll walk you through the model in a moment, but you want to know, if we say we're screening every individual at every appointment, is there, if you're not at 100%, what can you do differently to move towards the 100%? If you are at 100%, are you doing it in the way that you're asking questions in a evidence-based, thoughtful, non-judgmental way? How can you consistently improve? Do you even know who in your system, the data that Sidra just described, where you look at claims data and it's really not, you miss half the cases, I think that's going to lead to systems that aren't going to be as effective at targeting suicide if they don't even know who in their system died by suicide, or if people haven't been in their care. A lot of systems will ask us about, well, how far out do you measure, right? If you haven't seen your patient because after that 6-week visit, they don't come back for another year and they die by suicide 6 months later, should that count, so to speak, when you're looking at how many of our patients under our care have died by suicide? And I think, while we can't give you a strong and fast and say, always measure to the 6-month mark or the 90-day mark or the year mark, I think you should ask yourselves, what can you do? How often are you seeing people? I have a colleague who says we can make our data look amazing if we say we're only responsible for our patients for 30 days, right? But that's not really the goal of a framework like this or a suicide prevention program like this. What you really want to do is think about, how are we ensuring that we're not missing opportunities and that we know who is at risk and we are doing what we can to save their lives. Next slide. So I've kind of talked for the last couple of minutes more about what you need within the culture to change to do good suicide care, but there are clinical best practices. And first, means identify. You just need to screen people. You need to know who's at risk. You need to use an evidence-based screening tool. A lot of systems use the patient health questionnaire, PHQ-9, the ASQ, the Columbia Suicide Severity Rating Scale. Whatever you use needs to be standardized, evidence-based, and everybody in your system needs to be trained to use it. A big practice challenge would be if you're using the PHQ-9, for example, and you're not even looking at your patient as you're asking them about suicide, right? It's clear you're just doing it to fill in the electronic medical record, or your nursing staff or your techs preface it like, I'm so sorry I have to ask you this, but we have to ask everybody. Can you imagine somebody at risk who really doesn't know how to share how they're feeling and they want to tell somebody, but they've been told, yeah, I'm really sorry, it's kind of weird, I have to ask everybody. You're not feeling suicidal, are you? That's not the same thing as the questions are written in the PHQ or the Columbia, where it's really meant to be very conversational, but just very straightforward. Are you having thoughts about killing yourself? Do you wish that you would go to sleep and never wake up? The questions have been researched, and we know that it works. We know that when you ask directly in a non-judgmental, confident, patient-centered way, people will share how they're feeling. So you want to do a standardized risk screener followed by a risk assessment. And the risk assessment really looks at what is the person's level of risk. Do they have a plan? Do they have access to their means, so that you can develop an appropriate treatment plan and strategy for what comes next. Next slide. And what comes next with anybody at risk for suicide, both should be talking to them about, this is how our system will manage that suicide. We'll put you on a high risk pathway, meaning everybody in our system will know that you're at risk so that we can check in with you at every visit. Not everybody needs to go immediately to the hospital. I'm sure you've referred people to the ER who are not admitted, which means they're coming right back to you next week or in a couple of weeks, and their suicidal thoughts probably haven't really been reduced. But we know oftentimes hospitalization is not best for everybody. So what can we do instead? You can do a safety plan. And towards the end, I'll talk about, we have a website, zerosuicide.com. Everything on that website is free. But what you want to do is do a suicide safety plan. It's an intervention that talks about what are the triggers and warning signs, what are your coping skills, how can you manage these thoughts of suicide. You want, again, it should be a living, breathing document that you do at every visit with your patient who's at risk. It also includes a conversation about reducing their access to lethal means. So knowing what their thoughts are and how they will distance themselves from access, including confirmation that access has been reduced. So calling the spouse or whomever they lived with or the parent to say, for the time being, while Julie's at higher risk, can we take the pills out of the house or the gun out of the house? Or could you give Julie her pills and otherwise lock them up? And part of engaging somebody is just giving them hope. There are strategies and tools that work, and we're going to partner, and I've seen other patients like you, and we're going to get through this together. It's really just offering hope that this person feels heard, cared for, and whatever the referral is to your behavioral health providers in the region, that you're going to help them get there and ensure their safety, and that that they go to those appointments, that you're going to be part of their team. Next slide. In a system, and perhaps in your system, you may not have behavioral health staff on board. If you work as part of a larger system that does have behavioral health providers, psychologists, social workers, licensed professional counselors, there are treatments at work. If any of you are familiar with dialectical behavior therapy, or CAMS, collaborative assessment and management of suicide, cognitive therapy for suicide prevention, these are best practices in suicide prevention. I would recommend having some familiarity with these practices, again, in terms of educating your patients about what types of providers are they looking for, what kind of treatment exists. You really want to refer somebody to a provider who has specific training in suicide-specific care. One of the things that we know over the last 15 years or so of research is there are suicide-specific interventions that do work. I think when 20 years ago, 25 years ago, really the treatment strategies were treat the depression and the suicide will go down, treat the anxiety, treat the substance use, treat the relationship issues, right? Treat all the other pieces, and then hope that the suicide goes down. But what we found is actually that's not as effective as suicide-specific interventions. Next slide. And if you're going to make referrals, whether it's to the ER, whether it's to a primary care physician, to a behavioral health provider, you want these to be warm handoffs. You want to educate your client about what is it that they can expect from care. How often? What is therapy like? Many new patients in particular who haven't had therapy, or they've had therapy in the past and said it didn't help. Part of your job is to help coach them into what to expect, what can be different, what can be better. And calling in between appointments. Part of a good transition plan, earlier on in your pregnancy, you're seeing people less often, or after that 6-week visit, you're seeing them less often. But you can put into place what are called caring contacts, text messages, phone calls, emails. Julie, just thinking of you. We know you really, talked to us about some things that were stressful to you, and said, playing with your dog and going on long walks while you're on maternity leave would be really helpful to you. Hope you're getting a chance to do that. So they're very individual and they're meaningful. But what they're saying is, and we're still here for you. And if you're having a hard time connecting to a provider, we can assist you with that. Or we know how. We just want to let you know that we're here if you need us in the future. That would include giving people the suicide prevention lifeline number, which is 800-273-8255. You want all of your patients to have access to that phone number should they be at risk for suicide, or people in their network. Somebody's loved one can call and ask, what do I do? And as of this summer, 988 will be the nation's crisis number that will access the suicide prevention hotline, but also any other crisis needs. And if I can talk a little bit about that at the end, but there's a lot. You can also see a lot about that in the media right now, and more will come out in the coming months. Next slide. So all of these practices that I've already been describing, you have to train people in your system to do. It may be very uncomfortable to ask directly about suicide, and the more you practice, the more comfortable you get doing that. You may want to train your front office staff. If somebody cancels an appointment and they say, well, the last time I saw Julie, or when I called her today, or Julie called in to cancel her appointment, she really didn't sound like she was doing well. And you want to give some level of autonomy to your schedulers to say, Julie, how are you doing? Or for the scheduler to be able to go to the office and mention to the nurse or the physician, I'm really worried about Julie and want to reach out. You want everybody in the system to feel that they have a role in caring for patients. Again, when I was pregnant, I loved my OB, but the schedulers in some ways knew me best, right? The more you go in, and they had seen me with my other kids, and so in many ways, people often have really strong relationships, and you don't know where those relationships lie within the system. So similarly, I think, we get phone calls from our dentist to remind us to come in. We get phone calls from the vet about the dog. All of these kind of caring contacts and people within the system that aren't just the physician or in that role, often are having contact with your patients. So we want everybody to be well trained and well prepared, and that gets kind of back to the CQI process, which is, do people feel comfortable and confident to have these kinds of conversations and do these interventions? And if not, why not? And as a leader, how can you improve that? Where can you give people practice? Where can they talk about this? Where can they get additional training? Training isn't once. We know that the more you use skills, the more confident you feel using them in the future. And so if you have a training in January, but you don't see somebody that you think is at risk for suicide for, 6, 8, 12, 15 months, your confidence asking directly may have gone way down. So you want to increase training opportunities and chances to talk about that across your entire staff. And also, what are the policies? What are the practices? What are your clinical workflows? Who's going to call if somebody is at risk? Are you going to call, if provider A calls the emergency department or mobile crisis every time and provider B doesn't? You do want some practices that the entire office feels comfortable engaging in and knows what are the expectations. Who to call, who can you make referrals to that has had suicide specific training. So you really wanted these kind of practices and trainings both well documented. You want everybody to know where they are. You don't want to create crisis protocols on the fly when everybody's has high emotion and is very overwhelmed. These are the things you want to do, long in advance, roll out and make sure everybody is aware of, kind of like COVID. Right. I mean, aside from clearly the nature of having to deal with the crisis of COVID, over time it's settled into, here's the signs on the wall, and here's the practices, and here's how we're going to mitigate, contact. It became very infused in the culture. Everybody was very comfortable with it. Everybody was trained on it. Everybody had the same set of language and the same expectations. And that is what you want. You want suicide prevention and care to be just as routinized and comfortable across the system as any other kind of health related issue that you see in your office. Next slide. So that's a brief overview of what Zero Suicide is. It really is a framework that helps you to think about embedding suicide care practices that we know work, we know help to identify people at risk, and we know reduce suicide behaviors and attempts, hospitalization, and deaths. And I think is highly applicable to maternal health. We have a toolkit. It's at zerosuicide.com that I think you'll see a lot of primary care resources here that's applicable, I think, probably in your setting. We don't have specific resources for maternal health, but would love to partner with anybody who's interested in helping us to create those specific resources. Within the toolkit, we have a set of tools. So we have an organizational self-study, which is really kind of a needs assessment, where all the practices that I just kind of walked through, how do you rate yourselves on a scale of 1 to 5? We have a work plan that can kind of help you based on how you score yourselves on the self-study. We have a data elements worksheet that is right now getting turned into a data dashboard. So by the summer, early fall, we'll actually have a data dashboard that will do cloud-based analytics for all those pieces where I was saying you need to capture how well you're doing, screening, assessment, safety planning, lethal means, et cetera. It is an opportunity to really input your data and track your progress. We have a workforce survey, which is assessing the comfort and confidence of your workforce. Everybody in the system, there's a link that if you sign up can get sent out. Is the toolkit available in Spanish? It is not right now. That is a great question. We do, however, have an adaptation of the toolkit for Indigenous populations. So the toolkit, there's a link within the toolkit for American Indian, Alaska Native settings. And so how to make it more culturally resonant and some adaptations that are relevant in healthcare systems in tribes and in Indigenous settings. There are tools about how do you finance suicide care, what codes might you use to do screening and others. And we also have a free course, online course on counseling on access to lethal means that anybody can take. Next slide. So I walked through many of the resources. In addition to each piece within the model that I just walked through, we archive all the webinars that we give. We archive many of the tools. We have a lot of innovations with regard to, for example, how does this work with what kind of messaging can you share with the workforce? How do you tell them what their role is? We shot a series of videos with a partner in Tennessee, Centerstone. And we have something we call our outcome studies, which is what is it that, and I think we have about 20 or so of them. What is it that each of those systems, and they represent a variety of states and inpatient, outpatient, primary care, what would their main activities and their main outcomes? Next slide. We have a really robust listserv. It's free. Anybody who wants to join that, you can sign up for that via zerosuicide.com. There's about, I don't know, over 3,000 people on it, and anybody looking for what are the best practices in this population, or I'm really challenged by this situation. It's an incredibly giving, generous listserv where people don't want you to reinvent the wheel and are very willing to share. There's a lot of implementers. There's a lot of people with lived experience that will report, don't do X, not Y. There's a lot of researchers, a lot of leaders and executives. And we try to post feedback and any articles that have been published about zero suicide or suicide specific care. Next slide. I am the director of the Zero Suicide Institute. A lot of healthcare systems use those free resources on zerosuicide.com. And then some have asked for specific training to launch, adopt, sustain, evaluate their zero suicide framework and practices, just feeling that they were getting far, but they wanted to do additional work, and so they contracted with the Zero Suicide Institute to do this work. And through the Zero Suicide Institute, we also create a lot of resources. For example, that's how we were to share the Indigenous toolkit, was through some work we did with Indian Health Service. So oftentimes we may contract with the system and then push out free resources for the country when we can. Next slide. You can reach me. That's my email. You can visit our website, zerosuicide.com. But if you have specific questions, you can reach out to me. And we have time for some questions for me or Sidra at this point. So thank you.
Great, thank you both so much. That was such a fascinating presentation from both of you. Sidra, the overview of kind of the epidemiology and prevalence is fascinating. And then Julie, the zero suicide framework, there's just so much there, so much good stuff there. As our participants start thinking through questions that they have, I'm happy to kick us off. Julie, one question I have for you is, so the zero suicide framework, from what I understand, is being implemented in healthcare settings, but what about other settings? Like I'm thinking of child welfare, criminal justice, school settings. Can it be adapted for other sorts of settings? Has it been adapted? I would love to learn about what that looks like.
Yeah, we have adapted it. Some of those resources we haven't yet been able to make public, just we're still kind of revising them, but we did do work with a foster care system. I think it absolutely is applicable. You know, even here you can see in a primary care practice that's not a collaborative care setting, you're probably not going to do intensive treatment. So some of those pieces that, you know, that are really critical. A school is not 24/7 care. We have done some work adapting this though for schools, for school-based health clinics. We are on a grant right now to do some work in juvenile justice. The organizational self-study is available for corrections settings. I think it was the state of Connecticut did some work to adapt it to make the language more relevant for corrections. And if you email me, I can share that resource with you. So the only thing I would caution, so I think the answer is yes, it can be adapted when you think about those 7 components and what the research says about what works to identify and care for people at risk for suicide. I think, you know, Zero Suicide has a lot to offer. The only thing I think we need to be careful of is it is not necessarily something then that we say, great, we're going to do zero suicide with the police and with, you know, first responders and in my community and with faith leaders, right? There are other models for comprehensive suicide prevention practices. I think we also have to think about other risk factors, social determinants of health, you know, other ways. There's whole practices that faith leaders can do, for example. There's whole practices that communities can do. And if that's what you're interested in, I can send you links, you know, from now till next week. But I just don't want to conflate that zero suicide is the answer to all things suicide prevention. And sometimes people get a little jazzed by it. And say, you know, great, we're going to do it. And we're like, well, actually, there are better resources given the setting you're in. But I think really, if you think about what's a boundaried population where you have access to people kind of routinely, and some providers to actually have training to do some of that conversation and intervention, then zero suicide probably has relevance and can be adapted.
That's great. Thank you so much. Sidra, one question I have for you, since you are a researcher in this space, is what is kind of one of, if you could research anything in this space, what would it be? Like, what's kind of uncharted territory when we think of maternal mental health and suicide in particular? If, you know, grant funding wasn't an issue, and you know, what would be on your wish list as a researcher?
Right. Wow. Oh my gosh. What a great question. You know, I think so I am not an intervention researcher at all, but I think that interventions and the effectiveness of those interventions are the big gap in our knowledge about this. And that's for, I mean, not for lack of trying. I mean, there's lots of, you know, as Julie sort of was just talking about, there's lots of people, lots of organizations out there that are trying different things, right? Trying, you know, there are some proven models, but in general, like, suicide is rare, fortunately. I mean, it's more common than it should be, but it is still rare. And its rarity makes it hard to assess when the things that we're doing are effective at reducing the intervention. So like Julie brought up screening, so universal screening in healthcare organizations or other places. There have been, you know, sort of limited evaluations of whether screening in and of itself is effective at reducing the suicide mortality rate. There have been other evaluations that have looked at sort of suicide attempt rate and so on, but you know, what I care about for the most part is suicide mortality, is the deaths. And so I think doing research on sort of really large scale to understand, you know, what what are the interventions that work? What are the interventions that are kind of feasible to roll out in healthcare settings or other, other places? What are the things that work for this particular population that I think would be high on my priority list?
That's awesome. Thanks for sharing. I encourage participants to chime in with any questions. I do have one more for Julie, though. So Julie, you mentioned the 988 crisis line that will be launched hopefully in a few months. I know that's really a game changer for the mental health and addiction fields, so that individuals in crisis have a place to go. They have one number that they can call. How, from your lens, how can that number best be utilized by the maternal mental health community? And do you think that there's a need for specialized training in maternal mental health for those who are working the hotline, since it is such a unique population? And I'll add a unique population in that there are kids involved, so, and we know that there's so much stigma and fear among moms because of issues like potentially losing kids to child welfare if they admit that they are in crisis because of their mental health. So I'm interested in thoughts.
Those are great questions. I'll give a few thoughts, which would be, I think it'll be a soft launch because I think the questions that you're asking there's a lot still to be determined. Those are challenging. I think we have the stigma that you're talking about. We have to figure out how to overcome. What happens when you make that phone call? Who's going to come to my door? How's it going to work? Certainly, the last couple of years have shown us that, police and mental health has not ended well many times for people with mental health problems. And so undoing that is not going to happen overnight. And so, in neighborhoods where, calling 988, which is really the 911 equivalent, but for a mental health crisis, messaging about that will be really critical, and ensuring training on the part of who comes to the door to be compassionate is really critical. So there's a lot of work that has to be done there. And as you said, people who are answering the calls needing to be prepared and trained, not just for suicide, but for a psychotic episode, for a relationship issue, for a recent rape, for substance misuse, for maternal child health issues, new baby, postpartum depression, right? It's a long list of things that people answering those calls, and I believe some of whom are paid and some of whom are volunteers. So I think there's a lot of questions. I think there's a lot of incredible people working on 988 across the country, and a lot of attention to it, who are aware of all of these pieces that we're describing. And some of them will get, well done right out of the gate, and some of them will be revised and revised. I think, again, my sense is it's really being driven very statewide and very locally. So despite the funding that's coming from the federal government, a lot of decisions like what you're talking about are happening a little bit more locally. So reach out to your crisis systems. Many of them, we're a little 2 steps away from kind of my bullseye. So if I say anything that's wrong, feel free to correct me in the chat, or I apologize, because it's not something I work on day to day. I believe that those National Suicide Prevention Lifeline crisis call centers that are already accredited by the NSPL, will convert to be answering 988. I think you can find who's accredited by NSPL on their website, suicidepreventionlifeline.org. So look there. If they're, reach out and say, I'm interested, I want to partner, how can we support you? Can we train you? I think they're probably getting bombarded with some of those. So I would say try again, be specific. Those would be some ways. I think again, my sense as a provider, one of the things anyway, my system is doing, because we work so much with healthcare systems, we haven't had a lot to share yet because so much of this is still kind of TBD, but overall, being familiar with what will happen when you call 988, I think being able to train your team, train your staff, train your patients, when you call 988, this is what you can expect, this is what will happen. I think is really important, because anytime you're using that as a referral source, you want to know, like, are they going to pick up the phone? Who are they? What are they going to say? How are they going to answer? What the questions you're asking about? What if it's a kid? I think you can call on your own and say, as a provider, if I refer a mom to you with a child, a minor, what's going to happen? Like, I just kind of want to know so that I'm honest when I talk to my parents. So, there's been a lot in media about 988. We will be doing some webinars. We're involved in some message campaigns. The National Action Alliance for Suicide Prevention is also under the umbrella of the Education Development Center where I work, and the Action Alliance is doing a lot of that work. There was actually a messaging framework they released earlier this week. If anybody wants that, you can email me and I will send that to you. They did a webinar a day or two ago. It was filled to capacity, but it's been archived. So if these are things you're interested in, feel free to email me directly. And because of the relationship with 2020 Mom, we can also talk about how to help ensure that we're sharing those kinds of updates with you.
Great, thank you so much. And Jennifer asked when the 988 number will be launched. It looks like on their website it says July 16th, so it's coming up soon, which is exciting. I'm not seeing any other questions in the chat box, so this is last call for any questions. Feel free to type it in. But if not, I will just say thank you again to Julie and Sidra. This was just such a fascinating presentation. And I know that in the audience, we have people who have lost individuals to suicide, people who are, have struggled with maternal mental health issues themselves, providers. It's just such a broad, a diverse audience. And I think this was really powerful and impactful and informative to everyone, regardless of background. So thank you both so much. Thanks for the work that you do every day. And thanks to everyone in the audience as well for dialing in and for being here and soaking in all of this good information. So without any, I don't think we have any further questions. So we can go ahead and wrap up, and I hope everyone enjoys the rest of the conference.
Thank you so much for the opportunity, and thanks everyone for taking time out of your day to come.
Thank you. Agreed. Have a great day.